morning to everybody. So welcome to the second day of the ELAACC meeting, this second ELAACC meeting. Today I hope that we will do better in terms of timing because yesterday we had like some delay, so we will try to be a little bit more strict. And as you know, ELAACC, it's focusing on different topics. It's not about like a whole Congress on LAA and targeting all the topics. So today we're going to focus basically on imaging and also DRT and LAAC. So I think that it's going to be an interesting day. So welcome Ole. Ole is joining today, and we will have this interesting session about pre-procedural imaging options for left atrial appendage occlusion. So, I mean, Xavier, okay, you're here, so we will start with the first session.
All right, thank you for the introduction and good morning, everyone. So in this first presentation focused on pre-procedural imaging, I will try to answer the following question: are CT and 3D TOE the only valid options? So to answer this question, I first looked into the historical randomized controlled trials and the international registries, and I also looked in the ongoing randomized trials, and I think the answer is clear here. There is no 3D imaging modality required for to include the patients in these trials. Turning now to the European and US expert recommendations, you can read in both recommendations that the pre-procedural imaging is recommended. We can perform either a CT or a TE, but there is no specification on 3D TE, at least in the European recommendation, because if you read carefully the American recommendation, you can read that there is a potential superiority of the 3D CT dataset, which is suggested in the dedicated section. And this is maybe due to the collaborative work led by Kasper and Jens Erik, published in 2020 in JACC Intervention. And you probably all know this paper that underlines the advantages of the CT cardiac planning regarding all the anatomic and morphologic features of the left atrial appendage. And if we come back to the basics of the pre-procedural evaluation, you all know that we need to first exclude an LAA thrombus. We must carefully look at the anatomy to identify the complex LAAs, and of course we must look at the landing zone and osteum for an accurate sizing, particularly when we use ICE or micro 2D TE guidance in the cath lab. We can potentially optimize the transseptal puncture with advanced dedicated softwares, and potentially performed a full ALA simulation, including the delivery catheter selection, perform imaging simulation for ICE or TOE, and potentially simulate the device itself using FIOPS. One word about the thrombus detection. You all know now that CT has a very high specificity and sensibility for thrombus detection, particularly when we use a dedicated protocol, including a late phase acquisition, compared to transesophageal echocardiography, which is mostly based on spontaneous echo contrast grading, which is very much operator dependent. But the critics of pre-procedural imaging could also argue that the dynamic nature of thrombus can only be assessed on the day of the procedures, mainly by TEE in the cath lab. Turning to the anatomy now, I think there is no doubt now that the 3D data sets provided either by CT and now by 3D TEE is far superior to 2D TEE to evaluate this well-known classification that we've been using for more than 15 years. And it is even more important, I guess, with the new ELAACC classification proposed and introduced by the group here, which is really, I guess, a new deal regarding the anticipation of a complex procedure associated with complex anatomies. And as Adel showed us yesterday, this new classification is focused on every single anatomic features of the LAA potentially associated with difficult intervention leading to a potential challenge or risk or potential consequences and suboptimal implantation such as PDL or DRT. Once again, the opponent or the critics of the planification could argue that most of these anatomic features can also be evaluated by simple 2D TEE in the cath lab. And I think this is partially true, particularly for osteomeasurement, low takeoff implantation, long pulmonary ridge, and other anatomic features. But for very complex features like complex axis orientation, early sharp bend, I think we will all agree that the 3D simulation, particularly using CT, is far superior to the basics 2D TEE. What about sizing? I think there is no competition for sizing between the 3D modalities and the 2D TEE because we know, and we know since at least 10 years, that there is a risk of underestimation of the maximum diameter by TEE, which is obviously overcome by the 3D dataset using multiplanar reformation. And this is true for 3D CT, but also for 3D TEE, because we're going to use the same MPR techniques to get the best dimension and the largest diameter of the LAA landing zone. And there is an abundant literature on the comparison between 2D TEE and the 3D techniques. And all the papers published in the literature have shown the superiority of 3D regarding the evaluation of the maximum diameter of the landing zone. And these papers underline the risk of underestimation of this diameter and undersizing of the device. And because we all promote the technique, and we must all look for the perfect sizing for the perfect implantation. So is it really worth it at the end? If we look at the Euro intervention paper and the distribution of the complexity in terms of anatomy, you can see, and you already saw this diagram yesterday, that we mostly deal with quite simple LAAs. There is a large majority of simple to moderate complexity of anatomy. And if you look at the overall implant success and the peri-procedural complication, we see that with the increased experience of the operators, the implant success is nearly 100%, and the peri-procedural complications are going down. But we still have to face the risk of DRT, which is reported in about 2 to 4%, and which is for sure associated with the risk of complication in terms of stroke. And we have to deal with peri-device leaks, which are reported in at least 25% by TEE and much more by CT. And we also know that this PDL can be associated with complications. So we know, at least for DRT, that this is a multifactorial process, and I'm sure we're gonna see that later in the morning session. But there are modifiable procedural risk factors, and deep implantation is for sure a modifiable procedural risk factor. Pedro Cepas and Xavi's group have very elegantly demonstrated these risk factors by showing that deep implantation is clearly related with a higher risk of DRT for pacifier and non-pacifier devices, and this risk is proportional to the uncovered area. So if we are all convinced that we should use 3D planification, we need proof. And is there any proof in the literature about the efficacy of this 3D planning? I think the answer is yes. Roberto and the Swiss Apero group have published this very elegant paper showing that upfront CT planification is associated with an increased short-term and long-term procedural success. And if we go further in the planification, using the computational modeling to simulate the interaction between the device and the LAA, we see in this paper published by Ole and the co-workers that the use of FEOPS and computational simulation is associated with a decreased number of device use, a decreased number of repositioning, and less radiation exposure. And in terms of procedural outcome, during the assessed by the post-implant CT, there is a better sealing and a better complete occlusion of the patients with the complete evaluation, less leaks, and less risk of DRTs. So the question is, why do we not all use the 3D preoperative planification? I think the first reason is the increased cost and the hospital resources utilization, because I think in all centers all over the world performing the technique, they may not have all the 3D modality resources, and there is obviously a problem of reimbursement, particularly for CT. I think that's very true in the US, because I've tried to look what's the cost for pre-planification CT in the US, and the price varies from 300 to more than 6,000 euros, and the Medicare reimbursements today is $350 US. What about radiation and contrast exposure? I think radiation exposure is not an argument because in my institution, the mean radiation exposure is 3.2 millisieverts with the current prospective acquisition protocols. And for contrast exposure, we know that the contrast-induced nephropathy is very low in patients with GFR above 45 mils per minute. What about delaying the procedural scheduling? That might be an argument. It depends on each hospital organization. I think variability in imaging interpretation is not an argument anymore, given that we have proven the superiority of the 3D modalities to evaluate the maximum and mean diameter of the landing zone and the ostium. And the argument of the simplicity of cases, I think we never know. We never know before starting the procedures. So what about the ELAACC member opinion? I think most of us in the room are convinced by the utility of 3D modalities. You see that 83% of you use 3D modalities for upfront planification. Is it a problem of resources for the others? I think the answer is probably no, because in the second question, you see that the number of opponents goes from 16 to only 13%. So I think it's not a matter of resources here. And this is the distribution of the participants of the poll. So in conclusion, I do think that 3D planification is important for our patients and our procedures, because we must keep in mind that LAAC is an elective prophylactic intervention for stroke prevention. So we must try to achieve the perfect closure, meaning trying to get no PDL, no DRT, and of course avoid any major complication. We still use circular devices for complex non-circular anatomies, and we have now proof that 3D CT-based pre-procedural planification has shown a high rate of both short and long-term procedural success in prospective multicenter cohort versus 2D-based LAAC. Thank you very much for your attention.
Thank you, Xavier. Maybe first, audience, any questions, remarks there, comments, if you have? Yes?
Hi, congratulations for your presentation. This is Xavier Iriart from Barcelona. Well, you proved that it is crucial to do 3D measurements for improving our outcomes. What about 3D eyes for both planification and guidance of the procedure? Do you have any opinion on that? Thank you.
So I've tried to use the former generation of 3D eyes, which is only a 30-degree 3D, meaning that it's basically 2D. And it doesn't add anything, but the new generation of 3D eyes is for sure extremely promising. So regarding the device selection based on the 3D dataset performed by 3D eyes in the CAD lab, I think it's completely accurate, and probably Sergio will talk about that today. The question is, should we also perform another 3D modality upfront like CT to anticipate the complex implantation, which would be not associated with the LAA dimension, but more to the LAA orientation, for instance, as we saw yesterday with Adel in the classification paper. And the problem of reimbursement in Europe and re-sterilization of these catheters need to be addressed, potentially by the club.
There's also one comment there, maybe first. Yeah.
Thank you for your presentation. I would say I'm not a believer in CT. So you showed data that showed 40% leakages without CT. When you look in the randomized data, we have 25%. So I don't think that is a good example to show first. And the second, what is the clinical impact? All the trials that we have are done without CT, without 3D imaging. So when you think about Prevail, Protect, and all the others, Prague. So first of all, I would say, when you promote CT, you have to show that this has a clinical impact for the patient. We never know this yet.
I agree, and I think the PDL evaluation by TE and CT will be probably addressed in the afternoon. And I do agree with you that what we define as a PDL by CT is still under evaluation and investigation, and the clinical data about the impact of PDL that we have, and I showed just one diagram in my presentation, is today mostly based on 2D TEE. I mean, in the American data or in the big meta-analysis published last year by Samaras. So I do agree with you. We need data. I was supposed to talk about planification, so to do pre-op CT more than post-op CT. But I agree with you. We need data on the impact of CT planification. We have some. I try to show some, but maybe it's not enough, and we still need to work on the field.
Yeah, thank you, Xavier, for a fantastic presentation. I want to ask you about screening for LAA thrombus using CT. So we recommend a late phase acquisition in order to discriminate slow flow from real thrombus. And in your experience, when you have used those two acquisitions, do you still, in some cases, have doubt whether this is thrombus or not? And do you then proceed to TE, and in which percentage will you make an additional TE? That's one question. Second one is, one limitation with CT is that logistically it's typically planned some days before, and in several centers it might be 1 week before. Do you accept this still as, what is the time interval where you will accept a CT scan with a clear appendage without any filling defects? Will it be 1 week, or do you require it to be the day before?
To answer your second question, I'm not in position to require anything in the hospital with my radiologist. So we have a very good collaboration, and I can tell that in my hospital the CT are performed between 1 month and 1 week before the procedure, because there is no other option. Regarding the first question, the answer is 0%, meaning for us, specificity and sensitivity are close to 100%. I think the major strengths of CT performed upfront is that if we see a real thrombus during late phase acquisition, we're going to ask the referral physician to get his authorization to put the patient under LAAC for some weeks to decrease the thrombus size, and we're going to do the procedure. We're going to check on the cath lab with TOE or ICE, look at the size of the thrombus, and if it's smaller than it was, and if the risk is considered to be reasonable, we're going to use what we call the thrombus trapping technique. And so far, we haven't had any major complication with that strategy.
Well, thank you. No, I had also a comment, regarding the sitting, and I don't know what do you think. So basically, we're doing a TE, but the CT for me, it's something that it's in the ideal world, but then you go to the lab and coaxiality is not perfect, so then you have to do extra measurements because like the lobe of the device is not gonna sit, or it's impossible to sit the way that you plan. So I think that just do a very good pre-planning and then go with a 2D technique in the cath lab. I think that it's not good because you need to adapt. And I don't see people, like just scrubbing out and measuring again in the CT. I don't know if that's your case, but sometimes you have to draw the line in different places, so all your planification might be changed, the day of the intervention. So that's the only thing. And the other comment, it's I think that in the moment that CT provides additional information, functional information, something else, then it's when we're gonna say, okay, so we need it. But so far, I would say that it's comparable, Plus, like the TE gives you, like the guidance, through the procedure.
So the only comment I want to make, if you talk about pre-procedural planning, we also have to be realistic on who uses pre-procedural planning, yes or no. And if you do TEE pre-procedural planning, I never understood this concept at all. For me, it's a really big question mark. Why would you ever do this? Because most of the people have TEE during the procedure anyway. So it's kind of repeating an investigation. Why the heck would you ever do this? So for me, only pre-procedural planning, it makes sense if it's another modality which gives you some additional information which you don't have during the procedure. But like if your way of working is TEE during the case, why would you expose my patients to something extremely invasive? Like a TEE is one of the most invasive investigations you can do on your patient. Like a coronary angiogram for me is much less invasive than a TEE. So it is. Try to have, do you prefer to have a TE or a coronary angio? I'm happy to have right now on the podium a coronary angio, but not a TE, to be honest. So, no, but do you understand what I mean? Most of the people, for sure in the US also, they have TE during the procedure. So why would you do the same TE before? It doesn't give you any additional information.
From the time that we didn't have like 3D, techniques, like we had the micro, we had the ICE, that they don't have like 3D capabilities. But now that we have all these miniaturized with 3D, maybe makes no sense. No. Maybe.
I think that
for example, he doesn't do any.
the TOE.
Sorry?
You don't do any pre-procedural.
Well, no, I don't, and I was going to comment. So I fully agree with Xabi, and I like 3D imaging, don't get me wrong. We published on 3D angio to measure appendages. I think it's useful for operators to learn, to understand, but the problem I have with pre-procedural planning is it's not very lean, and if it would be provably better for outcomes, then I do it. But the problem is exactly what Xavi said. It's like there's a saying in the military, no plan survives contact with the enemy. And this is the feeling I always have when I do planning. You do the planning and you have this great plan, and then you go in the case, and life is not how you expect it. And from the data we saw, like, for example, it's always in studies, the old way is bad and the new way is better. And we see in these studies, implant success without 3D planning is 25% first deployment or something, I don't remember. I really have a problem reconciling this with observations from the clinical trials where no planning is used, where implant success is 99%, clinical outcome is good. And I don't think we have shown pre-procedural planning, for example, CT, to impact this meaningfully. Let's do research on it by all means, but if I have to choose, I prefer a device that allows me to adapt to circumstances over a perhaps suboptimal approach, which is then by pre-procedural planning somehow optimized, which is, I think, a questionable claim. I don't think it's a useful research topic, but I think it's a questionable claim to say you improve the outcome by pre-procedural planning.
Yes, just...
And what about the comment, I mean, who does the pre-procedural and TE during the case? What does it give you extra information? I don't really see it. I mean, except that you rule out thrombus, but how often have you had thrombus in your case? I mean, really, if you do 100 cases, it's less than 1%. So should you plan for something that happens less than 1%? I don't buy that. And many, yeah, I don't see it.
Just to detect thrombus, we may use echo contrast add to visual estimation. Therefore, it improves the sensitivity.
That's true.
I think I have many thoughts about what we are discussing. First of all, if you do a TE before, even a 3D TE, for pre-planning, you can also anticipate some complex anatomies that can drive your choice of device, or because what we are talking about pre-planning, it's not the high number of cases which are relatively simple that you can tackle during the case even by not knowing the anatomy. The thing is that when you go in the lab and you don't anticipate a very complex case, like a retroband chicken wing, short depth, and you discover that during the procedure. And if you have something, even a TE before, I think it's helpful because you know, okay, I will maybe choose this device, I will go for this size, so you increase the efficiency. So that's about preparing. So you can do the same with TE, but you have to not just look at the thrombus, you have to look at the size, look at the anatomy, so you can get the same information. So this is the discussion about TE and CT for pre-planning. And then I think something that we need to agree a little bit on is, should we strongly recommend 3D, whatever it is, CT or TE, doesn't matter, but I think a 3D measurement, even if it's in the lab or before, or CT or TE, I think that this should probably for me be a strong recommendation. Not to say you have to do a CT before, but you need to have a 3D imaging modality. Even if it's during the case, why not? I mean, if you have a good imaging,
even better.
But yeah, of course. But also during the case, you have a patient is fasting. You don't have the right dimension. You have to check for the. So sometimes it's good to have a CT before with more predictable measurement. Sometimes when I go in the lab and I have the CT before, and the CT tells me it's 28, and the TE on the day of the procedure tells me no, it's more 25 or 22, whatever the device. I trust the CT, and usually it's right. So. It's not so easy.
Yeah, and in addition, in very low volume centers, because here we're talking, to each other as experts. But yesterday I heard that the mean implantation number in Europe in every center is 25. The mean, meaning that there are a lot of centers implanting only few devices a year, and for these very, very low volume centers, I can tell you that the interventionist might be, very skilled, but in these centers, very often, the imaging specialist supporting the interventionalist maybe perform 1-2 procedures a year, and I can tell you that he misses a lot of information regarding all the traps, the complex anatomies, and having a kind of plan based on a 3D-based modality, whatever it is, I agree with you, helps a lot for these very low volume centers, because we want to promote the technique all over the world in low volume centers, and there are many centers who are not expert in the field, so they must be helped by getting all the information up front. That's my feeling.
So Lawrence, I mean, like, exactly. So we need
but I wanted to highlight the same thing. I mean, do you really need data for everything? I mean, it just makes absolutely sense to know the 3D measurements of the landing zone so that you can plan it and compare it with angio and TE once you do the procedure. If you have, if it's not aligned, you may think again, what was wrong, how can I improve? But if, 2 points, mainly if you have operators that are not experienced, they have an easy tool with the CT to distinguish an ELAACC score of 3 or more, then they may request help. Mm-hmm. If it's very easy, it's a 10 minutes procedure, nothing will happen. But if it's an ELAACC score of 4 or 5, it can be extremely challenging and also dangerous for operators that have less experience. So the other aspect is, and I would like to connect it now with the option trial, because in our experience, if we have established a collaboration with the EP lab, they don't have that much experience. So what we do is we do a pre-planning CT that is anyway available for the ablation, and we assess the complexity, and if it's not very complex, we do a concomitant procedure, and if it's more complex, we don't want to run into 180 minutes, as you have seen in the Amulet registry of concomitant procedure. I mean, nobody wants to say 3 hours in the lab. It really makes no sense. But if you do a pre-procedural assessment of the challenge, of the difficulty of the procedure, you can do it concomitantly or staged. Mm. And I think that's something we missed to discuss also yesterday. When you want to go for a concomitant procedure and when not, and this extremely depends on the complexity of the case. In our combined procedure, we have like 15 minutes on top of the ablation, because we select the right cases, and all the others are staged. And I'm convinced that this contributes to the safety. And I really don't think you need data for something which is very clear. I mean, sorry, 2D versus 3D measurements. It's clear that the 3D is better. I mean, who is not using CT to size the TAVR prosthesis? Who relies on the echo for that? It makes no sense.
But this is different because the echo in TAVI cannot give you the same information than in LAA. That's not fair. So,
sure, but it's 2D versus 3D.
No, 3D for sure. I mean, I think that we all agree on that. I think that we need to move because I said that we will do better, and we're already 20 minutes behind. So, thank you.
We'll be finishing in time here in this session. Yeah. So next speaker is Ian. Yes, Ian Buysschaert, about available pre-planning software pros and cons.
Thank you, dear Chairman, ladies and gentlemen. And so it's a great pleasure to be here and to put some more oil on the fire and to animate the debate. So I will give you an overview of what we have as available pre-planning software, pros and cons. Is it with this one? Yeah. So I have a few conflicts to mention. So I did a small study with FEOPS for which my hospital received a small grant covering the costs. The second conflict, I don't have access to Trimencio, TruePlan, and Vida, so maybe some of you have more experience with the software. And the third one, I'm colorblind, so you might see that I might have mixed up some colors. I really do believe that pre-procedural planning is key for a successful procedure. It's a complex anatomy. We have different modalities for imaging. We have different devices, different operators, and sometimes it can be a little bit confused. This is confidential information, but in Belgium in 2018, at the early start, you saw that there was a lot of missizing, and even in centers with bigger volumes, it improved the year after, but still you see it's not always the volume that will give you the most of the experience, so definitely it's not as easy as we think it is. We have two kinds of softwares that we could use, either based on the TOE imaging or based on the CT. And then you have different post-processing of the CT. The advantage of TOE and of the software that's running on your hospital PACS is that it's easily available, while other software have to be installed on your server, but you also have like FEOPS and VIDA, where you have to submit your case, you have to upload. There are some risks that we've discussed, and absolutely, I can't agree more. I've lost a patient in the early days where we wanted to exclude the thrombus before, and the patient died because of an esophageal tear. We had some problems of infections during the COVID. Since COVID, I've stopped doing TOE, and I've completely switched to CT. CT is using radiation, it's using contrast, but I think it's acceptable for the elderly. There is one remark: you need to make sure that the filling pressures are accurate, because most of the CTs are taken in fasting states, but you definitely want to have adequate filling pressures so that you have a dilated left atrium. The TOE and the PACS software is immediately available. The same for Trimensio or TruePlan. The FEOPS you have to submit. It will take at least 24 hours. VIDA, I contacted the company, but I didn't receive any reply, but I think the next speaker will present the software. And while you definitely need a dedicated TOE specialist who's there at every implantation, the Trimensio software, the TruePlan, is more limited. It's fairly easy to use it, and in FEOPS, everything is done for you by the company. We can discuss a lot of it, but I think sometimes we just need common sense. This is an example of a single plane TOE where you will measure 18, 20, 18, 20, depending on the angles. When you do a proper 3D, you will see that it's completely oval and that the diameters go from 19 to 33. And you never had 33 on the 2D. So definitely you need 3D evaluation, either on the TOE or on CT. This is the same measurement you will see on CT, so you definitely need, I think, a 3D. This is the confirmation on angio. What I truly believe is an interesting topic is the 3D rendering. You just, in one look at your image, you can definitely appreciate the morphology, the chicken wing, the cactus, the orientation, and there is no other software that will be able to predict you the 3D anatomy. You have it also with TruePlan and with FEOPS, where you can play around and you can see how it configures. VIDA does the same. But I think the 3D measurements are a must, and in Trimensio it will be semi-automatic for you, same as TruePlan and FEOPS as well. So you just delineate the region, and it will give you a segmented LAA and the numbers. The same for TruePlan, you just click, and it will delineate the anatomy, and it will give you the perimeter, the area, all that you want, minimum, maximum. So it's fairly easy to measure, and it will configure to the anatomy of the patient. With FEOPS, you have as well a lot of measurements. Sometimes it's too much. VIDA does the same. But then when it comes to the more difficult question, which device, which position, that's where you definitely have some improvement with the device simulation. In Trimensio, you can upload a small file, undeformed, where you can just put it where you think it should be, but you cannot deform your device, so it's just sitting there. There is a generically compressed device in the TruePlan, but it's not interacting with the patient, it's just an overlay. But the true advantage is with FEOPS, where you have definitely a host-device interaction, where you can play with the different devices in different positions, 28 distal, 31 proximal, 31 distal. You can see the compression as well. That might be too big, too proximal. So 31 distal is the way to go to. And indeed, this is what we could finally implant. Vida also have, on their website at least, the different simulations. You have some additional features on the software, the transeptal puncture. Well, TOE remains the state of the art, but Trimencio will also give you some advice where to puncture. They will do an overlay of the delivery catheter. I don't know if that's very useful. Watchman does it as well with the different curves, but you always use the double curve almost, so I'm not sure this is completely useful. FEOPS provides you different puncture site, but so far we've always used the inferior. You want the least angle towards the LAO. You also have the delivery catheter, but you have only one catheter for the amulet. It's a nice tool, but I think what is more interesting is the best implantation view of for your procedure. So Trimencio will give you a simulated angio, RAO 30 cranial 7. The Watchman will give you a projection as well, and you can play with FEOPS using the different views, but they will also give you an optimal view, which is fairly nice. You have some simulated TOE or ICE images. It's a nice tool as well. I don't think it's mandatory. Watchman TruePlan has it as well. There are some specials of interest. The thrombus assessment tool of TruePlan, it's kind of semi-automatic where they will measure the Hansfield units. FEOPS will give you the circumflex and the mitral annulus, and you can see if there is any interaction in doubt. Here you can see it protrudes a little bit over the annulus, but I think it's fairly acceptable. And then the next was the paper from Philippe and colleagues, where you can have the selected device. You can import the 3D file into your Fusion, and during the procedure, you have the overlay and you know exactly where to go for. They've done a very nice paper with great results. And then you also have, for the next speaker, the flow dynamics. When it comes to costs, well, what is available in your hospital is already cheap. Trimencio, it's an annual license. TruePlan, it's sometimes complicated, yes, no, package deal, so I still don't have it, although they say you could use it. FEOPS, you have to pay per procedure. But then last but not least, I can't agree with what has been said. We do have data. And if we don't have the data, we should generate data. We have data for the PAC software as presented by Xavier. The Swiss Apero, it's not randomized, but at least it's data. The use of a CT does improve the short-term and long-term procedural success. We do have data about CT. We do have randomized data. Randomized data, the highest evidence, 200 patients, randomized between standard of care or CT simulation planning with FEOPS. You've seen the data before. It's improving both the procedural efficiency and the outcome. Now you could say, yeah, but maybe your control arm was not good. Maybe they had not enough experience. The standard planning was maybe not good. But hang on, these were half of the room. These are maybe the most experienced operators. So on top of the best experience, there is still an improvement. So I don't know what else we need as data. We do have data. We did also in our country a small study, 100 patients, because I do agree with you, we need to measure. And so we asked 6 centers to do their regular standard of care before opening for the 3D simulation with FEOPS, and we saw that there was a change in 35% of the cases, and that the FEOPS predicted more and correlated more with what was ultimately implanted. So yeah, definitely it does improve, and we do have data, but we also need some common sense. So my take-home message, I think any pre-procedural planning is a must. You don't go at sea without a chart. You don't go to war without being prepared. The most interesting tools for me are 3D measurements, the 3D rendering, the best angiographic implantation view, and then, if possible, the host device interaction simulation. But I do agree, you have to familiarize yourself with some automatic feedback. You need to familiarize yourself with one technique based on the availability. Thank you for your attention.
Thank you, Ian. I think that, since the next, talk, it's gonna be like about the same topic. I think that we can, Jordi, you can just do yours, and maybe after this we can have like the discussion all together. Thank you.
Okay, so first of all, thank you for having me today. I hope that at the end of the presentation you find it helpful and useful, because my objective here is not present just the software per se, but how the flow dynamics can help to understand what is happening inside your left atrium. And it's true that maybe when you hear about flow simulations, you directly think about DRT, because you can have lotestasis and hypercoagulability of lot on those simulations. But today I want to go a little bit beyond, and just to show you how flow simulations can help you to understand the relationship between other variables, because device-related thrombus and other problems, I think that are all very related. So to do that, I will use this study that we just finished now. I cannot present all the results here because we are preparing the paper, but I want to say thanks, first of all the people involved, because I think that is a quite big study that I think that it's very well balanced between proximal and distal distribution, and also the type of device, plug device being the former Watchman and the Flex, and the pacifier device, the Amulet. So we ran not only flow simulations, but also analysis of the anatomy and clinical data, and all the modelers were blind, so only know about the 9% of DRT that we had when all the analysis was finished. So what I want to do today is just to show you a battery of cases that we had at the ideal study, and I think that are very interesting to discuss. One, as you can see here, is a very proximal cases, both with Amulet and Flex, that, as you can see here, are very well placed, and they are smoothly let's say, introduced in the left atrium, that it seems that this is a continuation of the wall, and it makes that you have a very good washing around the device surface, even in ventricular diastole and ventricular systole. But this, and this is a little bit a spoiler, it can happen because those two patients were in sinus rhythm. So it's very important how the heart is beating, how healthy your left atrium is, because otherwise you can have DRTs. So DRTs is not only about the position. I know when you place it proximally, you can also have DRT, because it's very easy to have only a small misalignment and then have subspaces that can generate recirculations at low velocities. But it's important to highlight that this has to take time. It's not a recirculation in one moment. I can now show you videos of 1 day of the heart beating, but this takes, it has to be a recirculation that takes time. On the other hand, I have this case that is very interesting, is from an Amulet, that if you see the result, the POS-CT, it's very nice placed, very proximally, but this patient developed DRT. And the thing is, the first thing that it has to be taken into account, that this patient has a permanent atrial fibrillation. So the heart was the left atrium was very dilated, and also was barely beating. So this produces that the flow coming inside was already at very low velocities, And then another thing that I think it's very unique this case is that the right superior pulmonary vein was very perpendicular to the mitral valve. So was destroying, if you allow me the word, like all the big loop that you can be generated here, and then it produces a lot of turbulence flow here. But another thing to take into account, I'm sorry to make it more complicated, is that this device was highly compressed. So what happens is that here it was very concave, so this also helps to generate this turbulence here. But of course, if you put it distally, it would be more likely to have these kind of situations even your heart is beating in a sinus rhythm. But I'm not saying that if you place it distally, you will have DRT, not at all. So here you have two examples with Watchman and AMOLED that you place it distally and the washing was perfect. Please don't get confused of the colors of this. So this is each color, the pulmonary vein that is coming from the left side or right side. And you can see here how the loop can be generated perfectly because this patient was in sinus rhythm and in can washing like all this area. So the same with AMOLED. Here it's true that we are coloring the velocity magnitude, so you can see that these are high magnitudes, but you can place it distally. So here my point is, okay, you can place it distally. If your patient is in sinus rhythm, it's okay, or it can be okay, but perhaps if this patient develops permanent atrial fibrillation, we can have a problem here. So another case that I want to show you is that, and this is a discussion that maybe also Laura afterwards can explain better than me, but 2D can be tricky, right? So at the end, the patients label this patient as a proximal one, and this is an anterior view, so if you check it, it can seem proximal, but then when you check the posterior view and the top view, you see that you leave in a space here that the blood can be stagnated there and generate the thrombus. And actually, this is the second kind of DRT that we have. So in the ideal study, most type of DRTs are on the top region of the pulmonary ridge, but the second one is in this middle part of the device, I would say, on patients that you have the left superior pulmonary vein like this and not aligned with the ostium, and then you leave this subspace here that is 135 degrees if you use echo. So what I want to use these cases, battery of cases, is that we have seen in the ideal study that proximal positioning reduces the risk, but I'm not saying that if you place it proximally, you will be safe. Also, I'm not saying that if you place it distally, you will have a DRT, not at all. What I'm saying is that, unfortunately for us, this is much more complex. You have to take into account how healthy is the atrial fibrillation of the patient, or how healthy is the left atrium of the patient, and other key factors as the position and also the hypercoagulation state of the patient. And all this we can do it with the software that I use, that is VIDA, and it's not only, as I said, flow simulations, but also adding clinical data and anatomical factors that will do the highest, or we can stratify the patients better. So in the ideal study, all the DRT cases were classified as a medium risk and high risk, none of them of low risk. So I think that at the end, we came up with a good assessment of the patients. So the old people that is here today is much more smarter than me, so one of the criticisms that can be done to this study is that we are not taking into account the anticoagulation therapy of those patients. So we maybe have high-risk patients that develop, that they don't develop DRT, and it's because of anticoagulation, and you are completely right. We didn't have this tool at that moment, but now you can apply the anticoagulation therapy, and this is not flow simulations anymore, this is biochemistry. So we are able to modulate the coagulation cascade, how the fibrin is reacting with the thrombin, and then if the thrombus is generating after applying different types of anticoagulation. I know that you don't apply 1 milligram of apixaban, but you know it's a model, so you can put the amount that you want. So the black is thrombin. So you see that you have thrombin with milligram of apixaban, but you still don't have the fibrin, and then with 5 milligrams of apixaban, almost there is no reaction. And this is without device, but now we are starting to validate this with device. We use a case that is very well reported and already published, that it was a recurrent, well, it was from a hospital clinic, and it was a recurrent DRT. So every time they quit the anticoagulation therapy, 2.5 of milligrams, they had the DRT on the same area. We ran simulations there, and we saw that it was just a recirculation over time there, but we couldn't simulate any more or nothing more. And now with the anticoagulation therapy and the coagulation cascade, we saw that the fibrin is reacting at the same place all the time, but when you apply the 2.5 milligrams of apixaban, there is almost no reaction. You can see some thrombin here, but the patient is quite safe. So the next step is, okay, how we validate this? My first idea, and it's up to you because most of the physicians, you are here that participate on the ideal study, but it's maybe do the same, but applying this coagulation cascade modeling on those patients and then apply the real anticoagulation therapy that they are having to see how it works. And then also to take this into account when you are treating a patient with anticoagulation. So again, it's just that you are doing the problem more complex. It's not as easy. You have a lot of variables. But now just finish 2 slides left. One is that we don't only have apixaban on VIDA. You can have the different anticoagulation therapy, and they are working quite well for the moment. And then this is not my work, it's from some colleagues, but they use the software and they allowed me to publish some snapshots because the paper is already submitted, is how they compare excision. It was a cohort of 33 patients from Netherlands with excision, and then they use the pre-procedural CT to apply a virtual implantation of the device and compare how are the results. And if you are able to do an optimal implantation, the results are much better than the excision. So I think that's all. I hope that you enjoy it, and if you have any question now or during the coffee break, I can answer. Yeah.
So I think, look, in order to respect the time a little bit, there's a pretty long coffee break there. So I think we have 15 minutes, and I don't want necessarily to push myself there to my presentation. I think it's more important we have a discussion maybe. Yeah, Casper.
Great presentation, and this is very interesting also for us to understand the flow mechanisms. But 2 questions. First, have you looked into, you say that the left atrial size and flow is perhaps a predictor. Have you looked into a cutoff for what size matters?
The thing is, but you are saying a cutoff, for instance, for the DRT to know all the variables?
Yeah.
This is difficult because, the cohort is 300 patients and only we had 27 patients with DRT. So to do a cutoff, this is very difficult. And the other thing is to do that, I need to take into account anticoagulation therapy, right? So in the ideal study, it's like 300 patients, but I didn't have at that moment the ability to simulate the coagulation therapy that those patients they were having. So, and I think that it would be one of the weak points of the study, if you allow me, and to be critical with myself, because, okay, I can have like a high risk and then do a cutoff, as you say, but if this patient, it was taking anticoagulation therapy, then the cutoff is influenced by this. I don't know if I explain myself. So if we do the study again and we apply this anticoagulation therapy, then I think that I will be closer to give you an exact answer on a cutoff.
And please explore that even more. Second question, which is perhaps to the room also, should these flow the knowledge we gain from this be considered for one indication or how we treat the patient afterwards? Because DRT is what we fear. This is the Achilles heel of this therapy. So when we do EP and ablations, we look at the left atrial size because it's a predictor of recurrence. So there we select patients sometimes on the size of the left atrium. Should we also consider that for left atrial appendage occlusion?
Yeah.
Or should we just disregard that and say all patients can be treated? It's only the post-procedural management that can be altered. And I don't think you perhaps know the answer,
no,
but
I don't
otherwise
know
the panel or
exactly.
anyone else can pitch in.
Well, here I think that, for the first time, probably we will have, like the ideal position. So it's like, that's, just the ideal position for, the best profile in terms of flow dynamics. So I think that if you don't get that, so I mean, of course you can run another simulation, but at least we have like a target, an objective. Because so far it's like based on what we think, what we believe, but now we know that, the pulmonary veins, the orientation play a role also.
And I don't know, and this is just my opinion, but I think that it's not only about flow simulations. I know that the colors, it's very spectacular and stuff, but my objective, for instance, would be like to learn from the flow simulations, and then one day it's like I don't need to run the simulations because I learned that if I have this pattern, this cutoff, as you were saying, you don't need to run simulations. Even doing with the echo data, you know what I mean? So is what my talk I would like to go about, is that use the flow simulations to understand the problem, not that I need to run a simulation for every case that I have.
Jordi, and I have a question, because from the CT you get, like a simulation, like a general simulation, just to go to the patient level, this functional information about the mitral, what data do you need? Additional data to adapt to the...
If you ask Xavier Iriart, he's a little bit pissed because it's too much clinical data and a very big Excel, but of course you need to know a little bit more about the patient, not only the type of atrial fibrillation that you need, but also how is the state of the patient in terms of echo, how is moving the heart. So we need a study of echo data, some clinical data related, as you said, on how is the hypercoagulated state of the patient, and then a CT.
So Doppler from the mitral and the pulmonary vein, so like
the
velocities,
ECG,
okay.
Yes, the ECG, and then some clinical data.
Okay.
I'm totally amazed by your visualization of molecules. As I understand you can actually visualize thrombin and you can visualize fibrin.
Yes.
Can you just allude a little bit more to that? Is that something that is possible with just a standard CT scan, or how do you?
No.
What is the technology behind?
So if you let me do like a wish list, I would ask you like a blood sample, and then I could extract all this information from the blood sample. But this is very difficult to do, I understand that. So all the reactions that you are seeing here is using the parameters that I can find on the literature that has been done, and then I use these parameters, and some cases that we have like the information. But I know that this cannot be extracted for each patient.
Another question there.
Yeah, hello. Ashan from UK, Nottingham. Excellent presentation and thought-provoking. This could be the future. So I have a question with regards to flow dynamics in atrial fibrillation. So in systole, the beat-to-beat there are a lot of beat-to-beat variation. So do you assume it's same, or how do you adjust for that?
As long as I have the ECG. This is a very good question, so thank you for that. I'm not saying that it's perfect. That's why I asked the ECG. And then I assume the variability that I can find on the ECG. But that's why also one of the problems that is a study. I think that there are a lot of patients that we have, like for instance, medium risk, and actually maybe are high risk, because the ECG that I got, it's from a sinus rhythm. And it was like much more before when the intervention takes. So I had the ECG that is from 3 months before the intervention, and then maybe the day of the intervention those change, or even after, and then all the beat changes completely.
Yeah. Thank you.
Okay, thank you. Very, very interesting presentation. Thank you. I have a same kind of a question as Jens Erik had. I'm a little bit amazed how you can assume the fibrin production.
Well, it's ongoing work. We are testing it. I'm not saying that it's perfect or it's done.
Okay, all right. Okay, that explains. Is it the AI model that you are using there?
No. It's not generative AI or something like that. It's equations that have been done by engineers. What we use is artificial intelligence to go faster on the simulations to solve those equations. But it's not artificial intelligence.
Okay, all right.
One final question
there. Very nice and very fascinating. Even though I don't want just to make my procedure too complex, but anyhow, do you have any relationship between what you have presented and just the smoke light effect during the echo? I mean, is there any relationship? You can just judge the same thing if simply you do the TE just to analyze, I mean, just which is, the flow in the left atrium. Number two, obviously, I think that probably we might be just much more willing just to use this modality for patients with a persistent atrial fibrillation. I envision that for paroxysmal atrial fibrillation, the scenario will be completely different than just the flow rate probably is not so, much evident.
Yes, so for the first question, it would be my dream, to be honest. And actually, I was discussing this with Philip Garot some months ago. The thing is that I don't have the data to do that, because to do the thing with echo, what I need first is a cohort of patients that they have like the echo views and then the CTs, because all the technology is based on the CTs, so I need to find the relationship to echo. So answering your question is I need the data. So for the moment, no, but I would love to, and I think that it's possible if we have the good data to do it. Regarding the second question, yeah.
I think that probably just much more prone for persistent atrial fibrillation. I don't see maybe just any value, I mean, theoretically for, patients who undergo appendage closure, but they are in a sinus rhythm.
No, I mean, I don't know if I get your question, I'm sorry, but you're saying if there is value for patients?
Just for persistent.
I don't know, I've seen so very weird cases here. I mean, the second case that I show with the amulet that is developing DRT, I don't know, I have some doubts. I think that also it can help in all the cases, because as I said, it depends a lot on other factors, the hypercoagulability state of the patient and the anatomy of the patient. So I don't know if I could be so sure about that. Yeah.
So I need, but why we don't have software pre-planning softwares for echo? I mean, we have like 3D echo, and we don't have. I mean,
yeah,
are you working or
echo.
somebody's working?
I would love. Okay.
Yeah. So Nina.
Okay, I think we are definitely not at the spot where you want to be, but companies are working on that. So they call it GEs here, I think. So blood speckle imaging or tracking could be a solution for the future. So it's not fine enough at the moment to really reconstruct the flow within the atrium, which is a very low flow. Yeah, so we are not at the point what you can show at the moment. But I think companies are working on that, and it might be very helpful because this is something you can see immediately after the procedure. So I think the future is bright.
Yeah.
Okay, I think just the final 5 minutes. Jens, you want to?
Jan and Ole, I think you have demonstrated that you can really gain more information of having simulation from FIAPS with the device implanted. But I think the limitation here is still the waiting time. So FIAPS is here. What is the future? Can we get this simulation in the future very rapidly? Because that's what you really want as cardiologists sitting there waiting to do the procedure. We have not time to wait for days. So I think it's a fantastic tool, but still the limitation is this time interval. Yeah.
Thanks for the question. First of all, FIAPS, it's a software, but it's also a service, and it's a big difference. I think there is still human there, so we have a quality control, and people look at the image. And so there is not only the AI part and the simulation, there is a service. This is the first thing. And about the future, yes, we are working on this, and we hope that we can provide in the coming years immediate interaction of the simulation. So you will drop the device in the anatomy and the simulation will be
Because indeed, ideally, it would be intra-procedural, yes? You would have 3D TE or 3D eyes, you would put some kind of a box on it, like you do for, if you do MitraClip, and then you, boom, you get a device suggestion of the device size, which is the best. And probably in the future it's possible, I guess. But
And
okay.
last thing, so we mentioned 24 hours. Yes, we guarantee 24 hours, but we can be below also 24 hours.
Okay, so let's, I mean, I don't want to go through all the slides I have. It's more interesting, we have for the last 5 minutes now still a little bit, we zoom a little bit out and we really have a discussion like the pre-procedural imaging and planning. Do we really need it? Because, I mean, of course we have pros and cons here, even in this room. And it's true if you talk with other colleagues or you go to US where you have a physician, he says like, yeah, but you know what? I mean, I've done hundreds of these cases and I never do anything before. I do everything in the lab. It's just easier. And indeed, from a patient's perspective, if this can be done, it's for sure the easiest, yes, if you don't need anything before. And so we also have to be realistic. We don't have to go exhaust all these pre-procedural options and make it more and more complex, especially if it would mean more complexity for the patient. So we have to be careful there that we're not just preaching for our own church. But I do believe, on the other hand, that pre-procedural planning in my own practice adds, and it's kind of a key for success of the procedure. So first, the title they gave me was Defining Guidelines, Consensus and Future Directions. It was really hard. I mean, I had to really think of defining guidelines on pre-procedural planning. Wow, it's like I have broken my head over it, but I was actually nothing to find in the guidelines. And Xavier Iriart, he showed very nicely consensus. There are some consensus papers which just come with some suggestion, recommendation to do it. And all the trials done, the new trials also on LAA closure, if you see what they recommend, it's just that they say there needs some imaging. Very often they already open up for TE or CT, and they say you have to rule out thrombus. And typically they don't say anything, they say you have to size, but they don't specify how. So it's too minimal what they come up with as a consensus or recommendation in the studies, I think. So the necessity of pre-procedural planning, imaging modality, what would it be? The point I wanted to make is, well, as most, like 90% of people in the world still use TEE during their procedure, I don't fully get what you get. Of course, I get what you get out of pre-procedural doing the TE. As Adele says, you understand the anatomy, you go prepared into the lab, you rule out the thrombus if you do it the day before. But still, it's limited. The additional information you get out is limited because you repeat it intra-procedural. What I think is, from just a pure practical point of view, if I have a CT beforehand, I get information which I never have from TE or from my intra-procedural imaging, like, for example, the most optimal implantation view, which is really key and for me to do this case and to make it faster and to not to make a lot of contrast injections, etc. So can a good pre-procedural preparation be a key to procedural success? For me, it is. Maybe for Tom here in the room and some others not, but for me, it really is. And it's maybe also looking from what I'm working in the structural field. So for me, if you do, for example, a TAVI procedure, I mean, the whole success of my TAVI procedure lays 60% in my pre-procedural planning and preparation. And just the execution is, I mean, of course it can sometimes go something wrong, but you know from pre-procedural planning exactly what you're running into, and that makes your case, most of the time, 99% of the time, successful. And I think it's a little bit the same for LA. This you've seen before, and I don't want to, this is maybe the last slide and I want to show you. So key successes, or the key for successful pre-procedural imaging, if you do then the pre-procedural imaging, is first on the number one, the golden medal for me is really indeed the 3D imaging. I mean, we have to stop doing these 0, 45, 90, 135 degree measurements on TE. It does not make any sense. I mean, first of all these measurements like 0, 45, 90, 135, I mean, they're all made in a different plane. So you have an appendage, you have your slice through your appendage at 0 degrees, you make their measurements, then you turn with to 45. That's probably in a slightly different plane. Then in the 90 is the other plane, 135 another kind of plane. What does it? It doesn't make any sense to make these measurements. It's almost better you don't measure anything then. So and so that's a problem. So you have to do 3D, and whether it's TE or CT, I don't think it doesn't really matter. But also, you know this image from before. Indeed, that's the second problem, of course, that you don't really, the max diameter is never really, you're sure it's a real true max. maximal diameter, was nicely shown by Ian as well. And then you have that additional problem of the different planes if you do the 0, 45, 90, 135. So I'm even a little bit actually disappointed, to be honest, in the companies typically that over all these years that they don't come up with more strong recommendations to do the imaging and the sizing in using 3D modalities. I think it's a responsibility from the companies also to learn customers, even if it's not high volume customers, but to train and advise the best practice. I think it's a responsibility they don't take. And then the other one is understanding the orientation of the appendix, so appendage. That's also important for your transeptal puncture typically. Also coaxiality, we know it's really important for your outcome of your procedure. And then looking beyond the LAA ostium or landing zone, I just want to show you, this is the last slide I want to show you then. Yeah, for example, this one. So, and I think I want to come there again with my parallel to for example, TAVI. If you would say you do a TAVI on a case and I give you just the annulus measurement, I can do the TAVI, sure, and in 90% of the cases it would go very successful. But if you have a full understanding of the entire structure, the aortic root, in this case, appendage, if you understand more, is it tapered, is it not tapered, how are the dimensions, just a little deeper in, a little bit more proximal. I mean, it definitely makes you take a better decision, final decision. And for example, here, these three pictures, you see the ostium and the landing zone are exactly the same. They're exactly the same dimension. It's just how different the morphology is and the distality of the appendage. I'm sure most of us, they would go for different sizes. Despite having the same ostium and landing zone, you would go for a different size in the left scenario than in the right scenario, yes? And that's just because you have to understand more holistically the entire structure. And if you do that, I think you also will do better procedures. So whether you do it with TE again or with CT, but I think it's a too far simplification is, for example, to go just for a measurement of an ostium. And I see many operators doing this, you know. Very often, in 90% of the true real world is people are planning for a procedure, they show you some TE images from the day before where you think like, what the heck? I mean, this doesn't serve anything, so that patient had a TE for nothing, to be honest. They show some images and say, yeah, you see there's an appendage, great. And you see there's no thrombus. But for the rest, you think, well, okay, it doesn't serve anything. So that's not good pre-procedural planning. And then also, intra-procedural, I think you really have to try to envision where the device will come to sit. It's not just simply measuring some kind of pulling a line at the ostium and then a line 10 millimeters down, if you then work for an amulet, or line a landing zone. It doesn't work like that. You have to try to envision where the device comes to sit, make some additional measurements for some bit deeper, bit more proximal. So it's more fine-tuned than just these one single recommended measurements. So I think with that, I want to complete, and maybe we have 5 minutes for discussion then, more, or coffee. No, yes, you have a question.
I would like to put a little bit oil on the fire.
Oh, more, even more.
I have to say I'm actually a little bit disappointed about the session. I go along with the direction that the field is taking, that we need to improve, we need to get rid of DRT, we need to get rid of leaks, and CT is doing the way. But to be on the podium and say, well, something that has worked, at least for one of the devices that we're discussing about, which is very forgiving because we only have 5 sizes, where we have multiple randomized data, prospective registries, where the 0, 45, 90, and 135 has given enough information to have a good result, just with a single sentence. I think that's even a little bit arrogant. And I think everybody is coming from a little bit of a background. What do we lose with CT? That was the question from Florian. Well, actually, we have hospitals where resources of CT and so are not that easy. So I need to argue why I would need that. And I go along with complex cases we may need CT. But at least with the Watchman, we are also fine with these 4 values, and we have good results and prospective results. So we need to combine these. You come from a background where you have difficulties going TEE because you need anesthesia, which I don't have. I do analogous sedation. So I need to convince my guys to do CT. Let's work together. Let's just not be on the podium and say, this is gold standard now. Let's not push away all the data that we have for 20 years.
No, but I don't think that's the message.
And final thing, it's plausible that we get better information with 3D TEE measuring, as you say, because we are missing planes there. Then again, I tested that. We did a prospective study comparing 3D TEE to the 4 measurements that we do with 0.5. In 150 cases, I couldn't prove we get better results with real endpoints like shoulders, leakages, or so. Well, obviously, we also now do 3D measurements, but at the same time, let's keep in mind, let's not make this more complicated than it needs to be. Let's focus on using the flow modeling to get rid of DRT. Maybe there's also even more than NOACs. It might have something to do with the multimorbidity of the patients, which is not going into the equation yet. It's just position of the device. Let's be open with all sizes and not just say now we are a church. Huh? Sorry.
No. Well, Martin, I think you misunderstood there then. I mean, the talk that I gave was indeed to say, look, I mean, you have to be open for anything, whether it's CT or TE, and I even started saying we don't have to overcomplicate the pre-procedural planning. Yes, that was the first thing. And the thing I wanted to say with Preach for Our Own Church is more like, yeah, we're very big CT. I was talking against myself. I'm a big believer in CT, but it's to say like, and many are using in this room, but I know out in the world, in the real world, there are many not using this. That's the point I wanted to make, to say we should not say that we have to use CT. That's the point I wanted to make, exactly. Yeah.
Actually, I had one question. We started CT, yes, because we tried to move. I really have difficulties. Now I have another 5 measurements, which sometimes don't combine with TE, and they don't combine with X-ray, and I'm more confused than I was before. So I would like that we go through a few cases, that we mix these measurements, that we try to understand what's the real measurement, where's the landing zone, how can we predict that better. I think that's where we stand at the moment. If you have a new center starting CT, they will be more confused than they were before with just doing TE. And
okay. I'm not sure.
Just a quick comment. I think that it's not fair to just rely on this monoplane because it was working in the past, because now we're closing appendages that are not the same that in the past, because now we are closing appendages that have high contractility, they are more elliptical, and I think so. Now with the paroxysmal IF, at least is what we saw in our center, that we are closing less sick patients. And the thing is that, for example, that I come from the imaging, for me to make a measurement in 135, I really don't know where to put the line. For me, I try, because for some studies they ask us to do that, and for me it's super difficult. And on the other hand, to try to do it with multiplanar reconstruction in TOE, it's super easy. So I think that at the end we need 3D imaging. It doesn't matter if it's CT or TOE, and the nice thing of to use 3D planning also with TOE is that we are trying to measure the same thing, because in the first presentation, for example, from Xavier, a lot of studies, they compare monoplane with TOE with 3D imaging and with all the things, so it's not the same. So at the end, I think that the community needs to move to make the same measurements. It doesn't matter if it's CT or TOE, but for me, to do monoplane measurement, it's super difficult, and I make measurement of a lot of appendages. So.
Well, and sorry, Martin. So I think that that's about democracy, and like free thinking. I mean, you think that 2D it's enough. You have like a lot of experience, but maybe the other people think that 3D, and maybe that's the majority. So everything is respectable. So, but it's true that like if you talk with in the past with people that work with only angiography, they were super happy, with just only angiography. And it worked, they didn't have complications, so maybe that's not the way to go. I mean, 2D works, but I think that it's like at least, you need to respect as well. So we respect that people that think that 2D works, but also respect the people that think that maybe 3D is better.
If you allow me one final point, I think there's also a difference between the devices. One is much more forgiving than the other. So if I miss size with the one, it doesn't matter. I can still make it proximal or distal. If I miss size with the other, it's either out or device. So that hasn't been touched on, and
that's a good point.
And we need to consider that. Nina.
Time for coffee.
Yeah, just a question, maybe to you, Martin, because we have two controversies. So the question is for you, Martin, and for you, Ole. So if you have different measurements coming from CT and TE, so which one do you believe in for your implantation?
Well, the first question is that with the IFU of the devices, I think so far I'm only aware of ones that come from TOE. And we don't have CT-based. If I'm comparing that to Tabi, and I'm coming from the same background as you, Ole, for years now we have CT planning, sizing, which is different to the
But
TOE.
that's what I said. I think it's they don't take their responsibility. The companies. I think it's a mistake. Yeah.
Well,
I don't trust these IFUs. I mean, on LA. I mean, because they're based on what are they based? They're based on some. I don't know. So that's the point I wanted to make.
But to answer your question, or your remark, is that when you do a screening from 0 to 135, it's more or less a suboptimal 3D. You're trying to search for the maximum diameter, and you never get the true one. So first of all, if you have the TE, the good probe, with 3D capabilities, why not using 3D capabilities? First of all, because then you get really an accurate measurement. And the second thing, I think the risk with only using 2D, it's the undersizing. Because you underestimate the maximum diameter. And I don't know, I mean, sometimes you think that you have done a good implantation, and we do a lot of CT follow-up, and we will have this discussion later on during the meeting, but what you see, you cannot estimate what is the risk of a CT leak because we don't have any data about outcome, but you can see that actually you have done not such a good job that you think that you have done, actually, that you have missed a lobe, so I think everything that you get from 3D imaging help you to get a better procedure. And also, when you go, as Ole said, if you are able to do a pre-planning, a good pre-planning, it's not the case for it because you have a big number of cases, you don't have availability of CT, so it's not available for everyone, I agree. But even the most complex case, if you have a ELAACC score of, I don't know, or whatever the complexity of the case, if you are prepared before, this case can go very fast. But if you miss something in the anatomy, you will change the device, it will take time, you will create complication. It is going to be a super difficult procedure that you can finish sometimes with a good pre-planning in 10 minutes.